Right, so I think we're ready to start here. So, good afternoon, everyone. I would like to welcome you to this webinar using Relational Inquiry Framework for Decolonizing Nursing Curriculum. My name is Keith Barrow, and I am the Senior Officer here at Kazan. Before I jump into today's presentation, I'd like us to all take a moment and pay respect to the lands in which we are situated. The Canadian Association of Schools of Nursing respectfully acknowledges that its national office is located on the traditional unceded territory of the Algonquin people. Kazan would like to acknowledge and pay respect to the Algonquin people, who are the traditional guardians of this land. We acknowledge their long-standing relationship with this territory, which remains unceded. We pay respect to all Indigenous people in this region from all nations across Canada who call Ottawa home. We acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders past, present, and future. Today's webinar will be a presentation that will conclude with time for questions at the end. To submit questions, please use the Q&A button at the bottom of your Zoom window. We encourage you to use the chat function to discuss and share with your fellow participants. However, the chat will not be monitored for questions during the presentation. Today's webinar will also use polls to engage participants on key topics. We will be using a short Zoom poll, and we appreciate your active participation. Please also note that today's presentation will be recorded and posted on Kazan's YouTube channel for future viewing. We will also be sharing the slides. And with that, I am pleased and honored to have with us today Dr. Rasha Wahid and Kim English from Trent Fleming School of Nursing. We'd like to thank them for coming together for today's presentation. And with that, I'll turn things over to them.
Thank you, Keith, and good afternoon, everyone. Welcome to our webinar. We are excited to be here with colleagues from across the country who share the same commitment of improving the future of nursing education. And this session hopefully will be a challenge to think beyond the traditional pedagogy and move toward nursing programs that are more relational, decolonizing, and socially just. My name is Rasha Wahid. I'm Assistant Professor at Trent Fleming School of Nursing. I'm the Compressed Program Coordinator, the Chair of the Curriculum Committee, and the lead of the school's Curriculum Redesign Initiative that started in 2021. My curriculum development experience extends for the last 10 years, leading the establishment of undergraduate and postgraduate nursing programs in Canada and internationally. Today, I'm presenting with my colleague, Kim English, the co-chair of the Curriculum Committee and member of the Curriculum Redesign Group. And we will be sharing with you an 18-month journey of curriculum transformation. And that's still ongoing, by the way, and has been guided by Dr. Gwyneth Dawn and Dr. Colleen Barco, the developers of Relational Inquiry. The title of our webinar is Using Relational Inquiry Framework for Decolonizing Nursing Curriculum. Before we begin, I'd like to take a moment to read the Trent University's land acknowledgement. We respectfully acknowledge that we are on the treaty and traditional territory of the Mississauga and Anishinaabe. We offer our gratitude to the First Nations for their care for and teachings about our earth and our relations. May we honor those teachings. As educators, practitioners, and learners, it's important that we acknowledge the land, but also to reflect on our responsibilities in relation to the land. And this includes asking ourselves, how do we teach, learn, and act in ways that honor Indigenous knowledge, that support decolonization, both in theory and in practice? So again, thanks for joining in. And what we will do in the next hour, we will walk you through the 3 key areas. First, we'll explain the reasons behind our curriculum shift toward relational inquiry approach at our School of Nursing. Then we will describe what relational inquiry is, the core components, and how we developed our relational inquiry framework based on that approach. And finally, we will share how this framework supports practical strategies for embedding decolonizing practices in nursing curriculum. So we hope you find this hour meaningful and leave with some takeaways that will help you in your teaching or in your practice. As we're talking about relational inquiry this afternoon, which is about being context aware and relationally responsive, we'd love to get a better sense of who is in the room in terms of your role and how do you relate to relational inquiry. So please take a minute to respond to this poll. The first question is about your background or about your role. Can't see anything else coming, so let me just very quickly, oops, okay. I'm so glad to see nursing students, by the way. It's amazing to see that nursing students are here with us in this room. We have mostly academic faculty, nurse educators, few clinical instructors. And in terms of how familiar are you with relational inquiry, it's kind of ranging between never heard of it or using some components in my teaching, which is amazing, or heard of the term, but maybe not use it. And there's also some that teach it deeply or integrated in their works, which is amazing. So thank you so much for sharing this with us. And I think before we talk about decolonization of nursing education, we first need to recognize how colonialism has shaped it and how it continues to influence the way we teach and we practice nursing today. I'll start with the nursing education that's been immersed within institutions that shaped by the colonial systems, which was designed around the Western ideals of science, the order, and also the hierarchy of the knowledge. That's still dominant how we conceptualize nursing professionalism until today. And we can all admit that Florence Nightingale's model was revolutionary for its time, but it also was deeply Eurocentric. It honored the biomedical knowledge and excluded some indigenous, Black, and non-Western ways of knowing and also ways of healing. And these exclusions positioned the European knowledge as superior and treated other ways or other forms of knowledge as less than. And this didn't just shape what was taught. It also shaped who was seen as the appropriate knower in nursing education and in practice. But colonialism didn't just shape the past. It continues to operate today through what we call the knowledge hierarchies, the ways in which certain forms of knowledge are acknowledged while others are marginalized. Even now, the Western knowledge is treated as objective or maybe universally valid in most nursing programs. And alternative ways of knowing, such as the land-based healing, the spiritual care, the communal knowledge, they're often limited to either elective or optional courses, or sometimes labeled as cultural topics rather than recognized as foundational. So we see the alternative ways of knowing is usually absent or mostly absent from our nursing core competencies or the health assessment standards that we teach our students, where the valid knowledge still means the knowledge that aligns with the Western evidence-based models. And this colonialization is reflected beyond the content. They're built into our institutions, from the admission process that sometimes disadvantage marginalized students to professional norms and classroom expectations as well that reflect the Eurocentric values of independence and objectivity. Students from racialized and indigenous communities, they often experience nursing education as culturally not responsive. And this is because the knowledge and experiences these students bring are either unseen or invalidated in our curriculum. I want to stress here that naming these issues is only to create space for critical reflection and transformation of our education. And I also want to stress that decolonization effort has provided us with what we need to do, but not much of how we can do that. And as we turn to relational inquiry, I hope that you will see the how in this framework that provides tools to challenge these inherent structures and reshape the nursing education as more relational and inclusive. So why did we decide to redesign our curriculum? First reason is at Trent Fleming School of Nursing, social justice is a core value that shapes the vision of our school. Also, our academic strategic plan in 2022 identified the Indigenous engagement and knowledge integration as one of its core priorities and school foci. In 2001, and while we were going through the internal review process of our curriculum, we identified clear gap in how decolonization, social justice, and cultural humility were reflected in our curriculum. We found that while we have it in some individual courses, or some individual courses already touched on these concepts, they were not embedded consistently across the program. Another reason is our geographic and relational context. So Trent University is deeply connected to surrounding Indigenous communities based on its location. And this proximity brings the responsibility and also an opportunity to engage meaningfully with Indigenous peoples, to their perspectives and to their knowledge. So that was a key factor. Another important motivation was the commitment to respond meaningfully to the TRC calls to action. And I think you all feel the responsibility as educators as we recognize our professional and ethical responsibility to address the ongoing impacts of colonization and to contribute to making change through transforming nursing education. One more key reason was the recognition that, like many other nursing programs, our curriculum has been grounded mainly in task-based learning and biomedical knowledge. And these traditional approaches focus heavily on identifying symptoms, performing nursing skills, or following some clinical checklists. And as we all know, that usually leave little space for our students to engage with the complexity of the real-world nursing practice or to respond ethically in some challenging context. And the final reason was that both students and faculty at the school voiced some concerns about the competency-heavy curriculum that we had, and students wanted to feel more connected, more engaged, and faculty wanted to be more involved deeply in relational teaching practices with their students. So these were the reasons to redesign our curriculum. And now, as we just explored some of these reasons to transform to the RI approach or relation inquiry approach, we had to decide on the curriculum conceptual framework, which we didn't have. And that's when we decided on the working on the relational inquiry. So what is relational inquiry? Relational inquiry, as described by Dawn and Varco, it's a way of practicing nursing that is highly responsive to the real-world complexity of healthcare. And that's exactly what we were looking for. The relation inquiry is centered on two key elements: relation orientation and inquiring action. Relation orientation means intentionally focusing your attention on what is happening at and between the intrapersonal, interpersonal, and contextual dimensions of care. The intraperson is what's going on inside yourself and others. The interpersonal, it's what's happening between people, and the contextual level is the institutional, the structural, the historical, the political conditions that also shape care. And this provides a disciplined way of seeing the relational forces that shape health and healthcare. The second element here is inquiring action. And here we must emphasize that relation inquiry invites nurses to be in a constant state of inquiry, not just asking questions of the patients, but ourselves, questions of the situation, the system around us, when we are providing care or having any interaction with our patients or even conducting our assessments. So questioning like, what is going on here? What am I privileging? What I'm not seeing as well. And this dynamic process supports better decision making because you are attending to meaning, to power, to context, and also to the patient's unique lived experience. Again, Donald Varco emphasized that we are always relating, whether you're aware of it or not. As a nurse, we're always relating. And the difference with relation inquiry is that we relate with intention. We ask, how am I showing up in this interaction? Whose knowledge am I centering? How is the context in this moment shaping the practice? So focusing on these levels of inquiry helps nurses to move beyond the task orientation toward more of a meaningful care. And it also supports something that we usually ignore in our education, which is the nurse well-being. By reducing the moral distress on the nurses, encouraging being present in the moment, which means also being attentive to self-care over being perfect in the skills or in the technical skills that you are performing. So relation inquiry is about enacting nursing values. It's the ones that we use just to teach in theory, but found it really difficult or challenging to take it into practice with the students or with our students. And it's a way now to bridge these technical skills with ethical practice in every situation that the nurse or the learner would have with their patients. Here are 5 core components of relation inquiry that I would like to share with you to just emphasize and deepen the understanding of this approach. And first component here is inquiry as action. And as you see, the inquiry is an intentional and an ongoing action in relation inquiry, which means you continuously and constantly asking questions that deepen your understanding of the people, of the system, of the context that you're engaging with. And in practice, that would look like pausing, and before jumping to any conclusion, it's about considering multiple perspectives and remaining open to uncertainty. And this is something that I really value about relational inquiry, where uncertainty was always something that we avoided as nurses. It's something that we embrace in relation inquiry. And inquiry here is how we resist the defaulting to run to checklist or care protocols, and instead just approach each situation with curiosity, with humility, and also with responsiveness. In this way of acting that invites relational nursing, and I love to call it relational nursing, as we have it in one of our program outcomes, where you are acting with people rather acting on them, and allowing our care decisions to be shaped by what matter most in that moment to this person in that context. Another aspect that we have is relational orientation. And relation orientation is an active way of being and engaging in every nursing interaction. And it means approaching people, situation, again, or systems with the intention to connect. Your intention as a nurse, as a learner, as a faculty is to understand and respond in the way that is adapted to the context and to the relationship that you're having right now with the person. So in action, that relation orientation would ask us to slow down, to be present, to listen deeply, and not just to the words that the person is communicating to you, but also to their emotions, to their body language, to the history that they carry, and also the power dynamics in that situation. Whether we are with patient, with a student, with in any context, this orientation shifts our focus actually from simply doing nursing to being and focusing in being a deeper relationships. We have also relational consciousness. It's another core component of relation inquiry that involves the ability to notice and to make sense of what's happening at multiple levels. One is within yourself or between people or across the system. And I consider it a mental and emotional capacity to hold complexity. And that's what we were lacking in our nursing programs. And I think that's one of the important core components of relation inquiry, because it just gives us that sense of what is unfolding in this moment, beyond the obvious, beyond the behavior, beyond what's immediate in front of us now. And for example, a student engaging with relational consciousness might recognize patient anxiety, but also, in addition, they have to reflect on the institutional routines, on the past traumas that that patient had, on the cultural disconnect that might be contributing to their anxiety. This is this consciousness allows us to respond with more in depth in our assessment, in our interventions, because we're not just reacting to any surface behaviors that we see, we are actually engaging with kind of layered realities that shape that patient experience, which again, that reflects the complexity of care and the real world complexity of providing care. There is also the knowing, doing, and being, and in relation inquiry with intentionally integrating the knowing, doing, and being. These are interconnected elements where knowing refers to integration of the knowledge, the contextual knowledge at this moment. And again, it's not just what we learned from the textbooks. It's actually what we come to understand through these interactions and relationships and reflections that we're having. Here also the doing involves the application of the knowledge in ways that are context sensitive or being context aware of it. And it's about how we act in this moment. And being speaks more to the presence, to the values, and our identity also as practitioners. And it shapes how we carry ourselves in that moment of uncertainty, how we hold space for others, and how we remain grounded in compassion and integrity. The last component is critical reflexivity, and this goes beyond the basic reflection that we teach our students, because critical reflexivity involves being constantly examining your own positionality, the biases, the assumptions, and how these influence our practice as well. And this is an essential component, in my opinion, for decolonizing nursing and confronting these inherited or internalized forms of power and also dominance. So as you can see, these 5 components, they reform pedagogy, but also they reorient the educational experience toward equity, relationship, and justice. And this is how relation inquiry can be a method of disturbing these colonial practices and co-create the nursing education that reflects the world that we live in. So development of the relation inquiry framework, as I mentioned, the framework process, the development process was deeply intentional. It was collaborative process that spanned over 18 months through extensive work that was rooted in the principles of relation inquiry. We brought together more than 20 participants between staff and faculty members from diverse teaching and research backgrounds. And these educators participated in a series of structured workshops that were focused on key themes for different stages or at different stages of the curriculum development. And these were reflective spaces for everyone that participated to experiment with a new approach and new teaching strategies that aligns with the relation inquiry, and also engaged in positionality exercises in a safe environment. And these structured workshops themed around relation inquiry, decolonization lens, and culture humility lens. And faculty and staff had several activities to practice this new relational teaching strategies, between reviewing the course descriptions, going through course design, learning outcomes, assessment, and all from the relation inquiry lens. I would like to say that key part of this process was our ongoing consultation with Dr. Gwyneth Dawn, the co-developer of the relation inquiry approach. We had multiple and regular meetings with her, and her mentorship helped us to stay grounded in the core understanding of relation inquiry, and making sure that this is a shared understanding, while also allowed us to adapt relation inquiry in a way that is specific to our context at the Trent Fleming School of Nursing. We also worked with an advisory group that included the Indigenous scholars, the students, community partners, just to ensure that this work is uphold the relational accountability and also reflected diverse knowledge systems. And we had a feedback loop were embedded through all the process, where the reflection from the faculty, staff, student, advisory group, and any critique or revision were constantly going on through the workshops, discussions, or sometimes at the curriculum committee as also items to be discussed, and also decision making at council meetings. And to analyze our progress, we relied on multiple sources, whether these are the transcripts that we had, the curriculum drafts. We had multiple curriculum drafts until we reached the final framework. And also we had reflective writings from participants. And all these insights shaped the final structure of the relation inquiry framework that I will explore with you next. So this slide demonstrates the relation inquiry framework, and it focused on both how we teach and what we teach. So let's begin with the two central domains of the framework that you see in the middle. The first is the relational orientation, which is the how. And this describes how we engage with learners, with patients, with colleagues, and the broader healthcare system. And it actually reflects our stance or our presence and our ways of relating. If you look at the left side of the diagram, you will see three interlocking gears that represent this orientation. First one is knowing and knowing, and this reminds us that knowing is always partial, and that humility is essential in teaching and in practice. And this embrace also the unknowing and the tension between that what we know and what we are still learning, especially when you're working across different cultures or systems and lived experiences that we are still exploring with our learners or our patients in any caring situation. The relational orientation also requires us to nurture the ways of being. And these are captured in the 5 C's: compassion, curiosity, commitment, courage, and capacity. I actually understand it as capacity for complexity as well. And at the heart of the relation orientation is the relational consciousness, which is the ability to recognize how our actions are shaped by and contributed to different levels of inquiry. And here the triangle in the middle is illustrating the 3 levels: the intrapersonal, interpersonal, and contextual. And nursing from this view is not just something that we do or something that we do for someone. It's something that we co-create, whether with the learner or with the patient, in relation to time, to place, to power, and to the history of and the context of this situation. So let's move to the right side of the diagram, which is the pedagogical enactment, and which represent for us the what. And in this domain, focus on what we actually do in the curriculum, the assessment and the learning design, and it guides the content of the curriculum, the tools and the outcomes that we aim to create. And at the core of this domain is the idea of learner as inquirer. This is in the heart of the framework, and this reminds us always that the learners are not passive recipients of information. They are actually critical and reflective participants who are co-constructing knowledge with us. And that's also encouraging encouraging our students to be always engaging in the inquiry as action, guided by the 5 W's: who, what, when, where, and why. And this foster active exploration and critical engagement in the real world situation. And again, this is what we were looking for. And that circle shape here represent inquiry as continuous. It's never complete. It's something that will always be constant and evolving with the context as we go. Surrounding this inner core is the different forms of inquiry, which represent the ethical, empirical, aesthetic, and socio-political. Also, again, reminding us that the evidence comes in many forms, not just one form. And it's not just about randomized control trials or Western evidence-based models. It's about meaning, it's about justice, it's about beauty also, and impact. And finally, the outer ring reflects the theoretical lenses, and here it brings the critical lens and the HP lens to see power, structure, and identity as part of every care situation that we go through. And specifically, the HP lens is the one that dives deeply into the lived experience and unique experience of that patient. So as you can see, we really aimed not to have a checklist or something that we just go for in order to redesign our curriculum or a protocol, but actually we wanted a living guide to guide us how to teach and how learners can relationally practice nursing after graduating from our program, and also to orient us towards the health of the people, the health of the nurses, specifically the well-being of the nurses, and also the health of the organizations or the system around us. So I'm just going to go briefly on explaining how we implemented relation inquiry in different elements of the curriculum. As you know, the curriculum development process is a lengthy process. Start with course descriptions, course design, learning outcomes, assessments, topics and content that you choose, and also the teaching strategies. And if we explain first how we integrated this, we will go that we started with the course descriptions. We started to redesign our course descriptions to center relational nursing care rather than viewing care as technical tasks. Because we had it, if you see in many of the nursing programs, the course description is usually heavy task-based, explaining what the course would be looking at, but this is kind of centering the relational nursing care as well. For example, in one of our health assessment course, the student will begin by exploring community and contextual factors, including social location, cultural beliefs, historical trauma, before moving into the individual assessment. And that's something that we were really keen about in the course descriptions. And this also support the students to see people as individual situated within the complex social and also system context. We also developed the course design to explicitly name relation inquiry, and as it's just as a guiding framework for us, and we made it visible in every course. And this visibility is just making the relation inquiry in our language. It's signaling to the learners and to the faculty that it's not optional, it's foundational. So that was really important. We went through this process process with Dr. Gwyneth Don, revision of all the course descriptions that we have, or the course designs that we have created. And this is one of the outcomes that we are really very proud of. Also, if we look at the learning outcomes also needed to kind of evolve from what we had in the past, from focusing on tasks to maybe being more relational competencies. And instead of outcomes like student will demonstrate knowledge of XYZ in nursing skills, we now focus on the relational competencies. So for example, the student will analyze how social, political, and historical determinants shape health experiences through decolonization lens, or through decolonizing lens. And these outcomes help the students to build this critical consciousness, or the relational consciousness that's necessary to practice nursing from a relational perspective. And that's what we were aiming for. And one of the most important changes was how we approach the content. So rather than creating one diversity course or adding a week on Indigenous health, we actually made sure that decolonizing and social justice are reflected and mapped across the whole curriculum in scaffolding order. So the learners will engage with themes like historical trauma or Indigenous health or intersectionality in every related course whenever it's relevant, according to the year and the level that they are at. And this was huge for us because this positions social justice, our core vision, as a central concern and not just an add-on in every course or in some courses and not in the other, which was one of our reasons to start redesigning and review the curriculum. We also realized that relational teaching requires relational strategies. So we moved away from relying strictly on the lectures or seminars toward more thinking about participatory learning methods. And these methods, such as the narrative pedagogy, where we aim to embed the lived experience and the storytelling in the classrooms based on the advisory group, who also brainstormed with us other ways of teaching strategies that's more inclusive. We have also the reflective journaling, which is helping the students to examine their positionality and biases in every course. And the community engaged learning that places the students in environments where they know that they are co-learning with and from other communities. And these strategies actually foster reflexivity, empathy, accountability, which are the core components of relational practice. The last thing is to align our assessment with the relational goals, and we started looking at different assignments or assessment methods to keep the learners in practicing the critical inquiry rather than just memorizing the information. And for example, the case studies that require the learners to engage in social context, in power dynamics, reflective assignments that ask them to explore their assumptions and values. And here is an example of a case study in a mental health nursing course through relational inquiry. And I would like to say that mental health was not, it was an elective course actually in the current curriculum, but it's now embedded as a mandatory course in our new curriculum in the second year. And this reflects our effort to work on these gaps that we had previously in our curriculum. And as you know, mental health is existing in every interaction we have as nurses, and we cannot just ignore the fact that keeping these courses as optional is not fair for our students. So here is just like a mental health nursing course. This is one of the modules. It's in the second year of our program. and it has a case scenario and it has learning objectives that goes around the relational inquiry, whether relation consciousness, critical reflexivity, how we examine power dynamics that influence the psychiatric or the psychosis in this case study. We have also activity where they can ask different levels of inquiry, and different modes of inquiry as well is allowed. And there's also activities where they are open to some of the theoretical lenses, such as the critical lens or the HP lens, which is asking more about what are the values, the support in the community for this specific person, and what does wellness look like from their perspective, and so on. So this is just an idea of how that was reflected in our courses. And now I'm just going to hand it to my colleague, Kim, to continue on the practical strategies of relation inquiry.
Thanks, Rasha. If you don't mind flipping to the next slide, that would be great. Thank you. So just as a quick introduction, and I'm just watching the time to make sure that we have time for questions. So I'll probably move through this a little bit quickly. I want to also just share my own positionality. So my name is Kim English. I'm a faculty member in the Trent Fleming School of Nursing. I have lived most of my life and currently reside within the Williams Treaties areas. And it was not an area I knew enough about, despite the fact that I have lived here most of my life. I'm a white female settler, cisgender. My family has immigrated from Ireland, Scotland, and England with their own complicated histories. And so I acknowledge that that shapes the work that I do. I began my own journey of learning and unlearning many years ago, when it became clear to me that throughout my diploma, undergrad, and graduate education, this has never been part of my socialization into nursing, to consider other perspectives in the same way, aside from, as Rasha said, that kind of cultural content. So it's become increasingly a part of my work in terms of the importance of moving this forward. And so in terms of why it's essential, we'll come back to some of those key pieces towards the end. It's really about relationality, reciprocity, and responsibility being the key piece related to the TRC recommendations. When we think about relationality, we think about relational leadership, relational ethics, relational accountability. And for much of the work of sort of shaking up our current curriculum and what we're doing, it really requires a level of relational courage to be able to, just even have conversations about the problematic nature of Florence Nightingale's work as we reflect on it now, and we think about some of those aspects. Next slide, please, Rasha. So one of the things I've thought about is sort of pulling together and bridging two ways of leading, learning, and caring in doing this work, and thinking about a call in to do things differently. I'm cautious to not in the work that we've been doing around decolonizing, not to hang our hat on one particular way. So we'll often hear references to two-eyed seeing and seven grandfathers teachings and braiding knowledge from different First Nations specifically perspectives. And I think it's important to understand the population and the community and the nations that you are working with because there's different ways of thinking and being and practicing. And so it's really about a bridging and a call in and a consideration of doing things differently, and a need to ensure that when we're doing this work around decolonization, because we do hear that a lot, decolonization. We're fortunate at Trent to have some excellent Indigenous scholars who we can talk to about, concerns related to this. And we just need to make sure that the work that we're doing is not a performative act, which, is a concern for sure. And certainly I think has been how it's been approached in nursing education in general, historically, or worse, going down the road of white saviorism in terms of looking to make things better in ways without partnering with communities. So it really does, as Rasha indicated earlier, require structural change and modification. We can't keep doing things the same way and doing the same work and say that we're decolonizing our curriculum, because we're not. We really have not effectively made change. Next slide, please, Rasha. So in terms of putting it into action, what does this look like? From the case study that Rasha shared with you, I created as much as we said we weren't using checklists, I did create a checklist just to help colleagues sort of go through, when I'm creating a syllabus, what does it look like from a decolonized lens, and giving some key areas to think about, which would be making some or addressing some of those foundational commitments. So embedding the TRC calls to action into the work that we do, ensuring that we're talking about UNDRIP, so United Nations recommendations regarding Indigenous people, that we're talking about the treaties, that we're talking about anti-racism, which then also means having a need for us to understand what all of those factors mean as well. Requiring content on Indigenous health, but again, making sure that we're embedding that as Rasha has indicated, versus just having a sort of a case study here and there, that we're talking about residential school legacies, that we're talking about the 60s scoop and birth alerts, things that have only recently supposedly been ended in many provinces and territories, but I'm sure we might say that they're still continuing in many ways, that we're talking about Indian hospitals, which often seem to be left out of the conversation as well. So ensuring that we have content regarding that we align with CASN's cultural humility and cultural safety standards, which have been updated for those who might not have seen that, really talking about the need to address systemic racism and ensure that we're providing trauma-informed care, which would be, for us as educators, care with our students as well in what we're doing. That we're affirming Indigenous self-determination in the work that we're doing in healthcare and rights to traditional healing practices, and also addressing things like jurisdictional boundaries and understanding what those mean in terms of federal and provincial responses. So I'll go to the next slide, Rasha, sorry. I think you popped there once, and yeah, I'll go to. So what does that mean when we look at developing our curriculum? Thinking about decentering colonial knowledge. So really critically analyzing the origins and biases in existing curriculum content, textbooks, and case studies, and replacing Eurocentric authority with an equal focus on local knowledge. So as much as we have lots of tools around, whether it's simulations or textbooks that we're using, they really are still coming from one lens. And so if we're talking about truly decolonizing our work, we have to be cautious not to be using those tools that continue to represent one perspective and only one perspective. So making sure that we are considering other ways of knowing and being, that we're integrating those plural perspectives and including teachings that are authored by Indigenous, Black, and racialized nursing scholars as key voices, that we're talking about the impacts of colonialism, not just with Indigenous people, because colonialism has impacted Black individuals. It's impacted our Filipino colleagues who, have seen some unethical recruitment practices because of colonial historical and continued practices into today. So we want to make sure that we're ensuring learning materials that reflect the history, health practices, and lived experiences of diverse people and communities, that we're contextualizing and designing that curriculum that are responsive to the realities and health needs of local and Indigenous communities, and addressing topics that might not always be comfortable for us, but we need to move into that zone of discomfort around the impacts of colonialism, environmental justice, and health inequities. I'll go to the next slide, Rasha. So what does that mean for us? It means, fostering reflexivity and critical dialogue, which also applies to us as faculty as well, that we are reflecting on our own teaching and learning, whether it's that I have shared something in a class and in a conversation with students, you found out that maybe what I shared was not completely true. So that's an opportunity for my own reflexivity to do some learning and say, okay, wait a minute, I sort of came with one lens. How can I shift my learning? Let's talk about that so that we can learn together. Fostering that reflexivity, that critical dialogue, encouraging faculty and students to reflect on our positionalities and how colonial power dynamics really affect learning and practice, and shape what they might be seeing in their organizations. Because again, we can talk one way within our curriculum and what we're doing, but the students that we're working with are still going out into other agencies, which may not be doing the same work as we do. So how do we ensure that carries through with the work that we're doing? Really about considering how we can transform that educator role to be more of that facilitator on this journey, to step back in some situations and to create safe spaces for dialogue. I'll go to the next slide, Rasha. So for us as faculty and educators, it involves asking ourselves some of those questions, demonstrating that reflexivity ourselves. When I think about Indigenous knowledge, think about whether I'm using this as an opportunity in my class to center Indigenous knowledge or ways of knowing. Am I the right person to do this? And that's an important question to ask as well. Is this appropriate for me? Again, having had the benefit of some Indigenous scholars within our university, I've been able to have some of those conversations to say, would this be right for me as a settler to have those conversations? And so it's helped to sort of shape a bit of an understanding and self-assessment about, which spaces should I enter into and which spaces should I not? And if I shouldn't, then how do I engage and partner safely with those who should be sharing the knowledge? Am I using a strengths-based approach or a deficit lens to discuss Indigenous people, health issues, or nursing safely within Indigenous communities? So really focusing on that strengths-based and talking about that using that lens as a key part of our practice. Is my approach inclusive? Is it performative? And do I possess the knowledge to even be talking about this? And if I don't, how do I work to obtain that? I'll go to the next slide, Rasha. So some pedagogical approaches to consider are things such as experiential learning, and land-based learning really should fall into that as well. Experiential learning, perhaps, engaging clinical opportunities with Indigenous communities. And the key wording here is with. So that involves time. That's about partnerships. It's not us coming into a community to say, we're coming in and this is what we're going to do. It's developing those partnerships. And there's one community I've been working with for 2 years to build partnerships, and we've yet to have a placement, but it's coming. It will happen at some point. And so thinking about opportunities for land-based learning and understanding the role of traditional medicines, if you have someone who can take students and teach them that. Thinking about land acknowledgements, and is it a statement that I'm making in my class, the first class, and I never come back to it, or am I regularly revisiting my own commitment to action and reconciliation within each of our classes? And I'm demonstrating that in the work that I do. Considering again that critical reflection, am I taking that time to really think about those power dynamics and how they might be working in our classrooms? Using case studies, but again, ensuring that they're not performative in developing those case studies. So ensuring that they really are coming from that strengths-based approach, that they are highlighting some of those challenges that we might see, but again, pulling in that strength-based approach. And if we can, really considering co-design where we're able to. I'll go to the next slide, Rasha. So for assessment strategies, thinking about authentic evaluation, coming from a trauma and violence informed approach to consider evaluation. What's most important to know in this particular class that we're undertaking? Is it important to have an exam? If not, what other things can I do to be able to develop an understanding? Could we have some collaborative projects that, maybe in the end, maybe it's something that builds over the course of a term, and we come out with a particular idea around a collaborative project to make change. Thinking about inclusive evaluation criteria and what that looks like. And so, are we asking questions about anti-racism and the students' role in addressing that? Are we considering biases? And I skipped over clinical courses because I wanted to pull this into that component as well. So in clinical courses, we have a tendency to continue to focus on competencies, often technical competencies, maybe some leadership competencies. But are we asking about competencies related to decolonized practice? Are we asking about, do we give students an opportunity to consider perhaps, what did they do to prioritize cultural safety for a client in their care? What did they do to address bias in a situation? Having that as a key component of clinical practice as well. I'll go to the next slide as well, Rasha. So there are some common barriers, which are not probably a surprise to many of us. Often institutional and structural resistance can come at many levels. This work, as Rasha indicated in the beginning, really does require more than just curricular change. It requires change for everything. It requires policy change within departments. It requires changes to admission practices. For truly entering into a decolonized approach to our education, it means changing everything. And really reconsidering what each of those practices mean. We've talked about the curriculum content and resource challenges. Again, we have a set of tools available to us right now that aren't very effective. So how do we use those tools or look for other tools that are? How do we, if I'm using, say, for example, if I'm using Canada's food guide, am I also then perhaps talking about the problematic nature of Canada's food guide? Its evolution. Where did it come from? How it links to intergenerational trauma for residential school survivors, for those who are in Indian hospitals, for example. Thinking about cultural and attitudinal barriers, again, we may see this from some of our colleagues also, who might be in different places of learning and understanding. And so that presents as a barrier. Some practical implementation hurdles. I gave you the one just specifically around clinical placement. So while we're doing one thing within our institution, our students are still going out into clinical settings that aren't doing the same work. So how do we navigate that? And then again, we just have to keep coming back to those power dynamics and marginalization and the impact of those. Next slide, Rasha. Thank you. So I'm sort of rushing through, unfortunately, just because I want to, leave a little bit of time for some questions. But I think more importantly, the call in to all of you would be a call to action to really think about our requirements when it comes to, or our responsibility when it comes to the TRC recommendations. We're reaching the 10-year point of the release of those recommendations. We know that most of those recommendations have not been achieved, including within education and health. And so each of us have that responsibility to take this forward and think about those changes that we can make within our own institutions. So I'll stop, recognizing that we are running out of time for questions.
Thank you, Kim, and thanks for everyone who joined. I wanted to look at the, I don't know where to start, Kate. Is it the chat or the Q&A?
Yep, it's just the Q&A here. If you have access, we can take a look at some questions to answer. You have about 3 minutes.
Yep.
So maybe I'll jump in, Rasha. I see the first question about this sort of change requires commitment and buy-in. How do you ensure leadership commitment? What other resources were provided? And how did you ensure faculty commitment to the notion that this is not being optional? Which is a great question. I think that's always an ongoing challenge, right? In terms of that buy-in, especially when you have processes that take time and there's a need to move things along. I think it's about demonstrating again that relational courage to say that this is important and these are the resources that we need. So Rasha can probably jump in and say some of that too, that we were able to ensure we had some supports to be able to bring Gwyneth to us a number of times to work with us, which was amazing. And I think in terms of ensuring faculty commitment, that supported that faculty commitment because, she was there in the flesh and she was having conversations with people and helping them see how this would fit within not their current courses, but current approaches to teaching and current content.
Mm-hmm. And I would add, Kim, that as I joined Trent into 2021, we had this discussion, but there was an agreement within the school that we needed to go for a different approach. And this agreement, I think, helped us a lot, that everyone was thinking like, oh, the curriculum hasn't been changed for so long. We needed to move forward, and what would be the vision to move forward? And I think these discussions helped a lot. The other thing, as Kim said, when we had Gwyneth with us, it was really huge factor because it was grounding us into the relational inquiry core components, but not just in what needs to be done. It's how we're doing it through the workshops, through our relationships together. So that was really, I would say, was a huge factor. And plus, as you know, in every institution, you might have some resistance, and I've been doing a curriculum in different institutions. There's always, the change is always difficult, but I mean, with the persistent, with the support that you're getting, you just keep moving forward. I don't know how to see the chat. Kim, is it, are you on the Q&A?
I'm on the Q&A. Yeah, I'm on the
Okay.
Q&A.
Okay, so maybe I need to stop sharing and also check it myself, because I realize it can be distracting to others when I'm.
Yeah, it is 2 o'clock now, so I think we have time for maybe one more question, and then we can end the webinar.
Okay. How do you decolonizing curriculum such that is not undergoing major redesign? So I'm seeing one randomly. What are your recommendations for decolonizing the curriculum, such as using the relation inquiry framework that's not undergoing major redesign? Well, this is a really very good question, but I do think that this process of decolonization needs somehow major revision. If you're going to focus on only one course, it will be fragmented somehow among some courses, but not reflected or mapped on the whole curriculum. So I would really encourage or recommend that somehow an agreement, that you come to agreement where we need to do some major redesign. And this could be like for year one, maybe you can start with the first and second year somehow until you just build it on the other years. But it's really a huge process that needs major redesign rather than just different courses.
All right. Well, thank you everyone for attending today, and a big thank you to both Rasha and Kim for their presentations today. And with that, we will be ending the webinar. Thank you, everyone.
Thank you so much, everyone. Thanks, Keith.